Hi, everybody. I'm Jay Silverman. I'm a professor at the University of California, San Diego, in our Center on Gender Equity and Health. And I'm presenting today on behalf of my other colleagues at GEH, as well as our colleagues at IPAS in Bangladesh and Population Council in Kenya. So today I'm going to be quickly describe two different trials we've done of an intervention we call ARCHES, which is addressing reproductive coercion in health settings. ARCHES is a brief clinic-based model to address both intimate partner violence and reproductive coercion in an attempt to increase the reproductive autonomy of women and girls and reduce, as part of that, GBV. The two trials I'll be talking about today, one was in around urban Nairobi, including 6 clinics offering family planning services. These were arranged in matched pairs for controls. And in urban Bangladesh, the trial was among women who were receiving abortion and post-abortion care in 6 clinics across urban Bangladesh that were randomized to intervention and control. Both had follow-ups. The follow-up in Bangladesh was 12 months, and the follow-up in Kenya was 6 months. So to take the time to really talk about what we learned from these trials, we learned that ARCHES across these different contexts was scalable and adaptable. It was implemented with quite high fidelity. It was considered feasible and acceptable to both clients and providers across these contexts. And in contrast to a lot of the work that's been done in the past around interventions related to IPV, we have very high rates of disclosure of intimate partner violence and reproductive coercion to providers among women and girls who were having those experiences. Really, in terms of thinking about reproductive agency, we did increase use of modern FP use in both settings and decreased incident pregnancy in both settings. There was also a decrease in unintended pregnancy, but the N, particularly in Kenya, was quite low. So we did not see that, and we did not look at this in Bangladesh because of the nature of the clients. We, very importantly, across both settings, decreased physical intimate partner violence significantly. We also increased awareness of intimate partner violence services in both contexts. So that's extremely important. The more complex results, there are more complex results around reproductive coercion and sexual violence. These did decrease in the intervention clinics, but they decreased significantly more in the case of Kenya in the control clinics. And we are looking for explanations around that, whether we had more people who were experiencing pregnancy. During the follow-up, we need to take a good look at that. But really, to just sum it up here, that this ARCHES was was implemented with great fidelity, with high feasibility and acceptability, and moved or facilitated women's communication with providers around intimate partner violence and reproductive coercion, such that these issues could be discussed and addressed in the lives of women and girls, again, moving to maximize their reproductive agency, their reproductive autonomy. Thank you very much.